Well, hi everyone, and thank you for coming. Nicole, thank you for the lovely introduction. And yes, as you reviewed, today we're going to talk about a two-hit hypothesis for germinal matrix hemorrhage and review both clinical and bench science research that's led up to that hypothesis. I'll say that I'm going to leave time at the end for questions and, welcome some discussion then. So in the Crouch Lab, we study brain vascular development, and our thesis is that blood vessels are much more than passive conduits for nutrient and oxygen delivery. Instead, our perspective is similar to the 17th century Dutch anatomist who said, blood vessels are ubiquitous and tissues are only blood vessels that are variously arranged. Now, this theme of the critical connections between the growing vasculature and the growing neural cells is one that I will refer to over and over again in this talk, because I think it's central to the cause and the clinical manifestations of germinal matrix hemorrhage. So here's a review of our outline for today. We're going to first talk about the epidemiology and clinical manifestations of germinal matrix hemorrhage. These are the key points for your board review. And secondly, we'll then talk about human brain vascular development and review some new findings from my lab on how human brain blood vessels develop, and hopefully show you some of the beauty and mystery of studying this topic. And then in point number 3, we're going to highlight new unpublished data on the mechanisms of germinal matrix hemorrhage. I'm really passionate about having treatments for this disease in the next 10 years, and I hope some of you will be inspired to work in this area as well. So let's jump in and review some data that is hopefully familiar to some of you. Now, recently, there's been a lot of lay press and academic press about the dueling trends of increasing survival and increasing impairment in preterm infants. So this was a review by Ravi Patel et al., who looked at survival data from the NICHD Neonatal Research Network amongst babies who were born between 22 and 25 gestational weeks. Now, during the time period that they studied from 1993 to 2015, survival at 22 weeks did not change. And I think as many of you are learning, this is likely because of different institutional policies on whether these babies are resuscitated or not. However, the critical, ELBW or, extremely low birth weight ages of 22 and 24 weeks, we did have improvements in the survival of these babies, especially in the latest time frame between 2013 and 2015 compared to, 25 years prior. And, encouragingly, survival at 25 weeks remained steady. And, overall, these babies we think of now as having a good prognosis. However, we unfortunately have not made as good a progress with reducing the morbidities associated with prematurity. So this paper by Matthew Rysavy noted a range of survival between different institutions at the same gestational ages, so now between 23 and 26 gestational week. Importantly, however, at each gestational age, a significant percentages of the infants who survive will have moderate to severe disability, and the younger the gestational age, the higher the risk. So what are the underlying causes of this moderate to severe impairment? In this study by Barbara Stoll, her group defined 20-year trends in areas of major neonatal morbidity. And I'll start through walking through all of these different conditions, although of course we'll end on germinal matrix hemorrhage. So first, I'll note that as a field, it's encouraging to see that we've improved in our rates of late onset sepsis in the past 25 years. However, as you know, the topic of our discussion today, intracranial hemorrhage, also called germinal matrix hemorrhage, and its sequelae, periventricular leukomalacia, we have not made any progress, in the past 25 years in these conditions. And finally, in the interest of educating you overall about the hot topics in the field, the rates of bronchopulmonary dysplasia in this data set also increased, which is, something that's also discussed a lot. So this trend, coupled with the increasing survival, highlights the need for a better understanding of the pathophysiology and the physiology of organogenesis outside of the womb, so that we can help all preterm babies not only survive, but also be healthy. So to focus on our topic for today, germinal matrix, also called intraventricular hemorrhage. So these are images from my postdoctoral fellow, my postdoctoral mentor, excuse me, Dr. Eric Wong. Dr. Wong is a neuropathologist who's been at UCSF now for many years. And about 15 years ago, he had the vision to start to collect the brain tissues of babies who died of different conditions in the NICU. And so now we have a brain bank of about 20 babies who've died from germinal matrix hemorrhage that hopefully we can use to fuel discovery and therapies in the future. To review some of the basic statistics about germinal matrix hemorrhage, it occurs to about 20% of our lowest gestational age babies, the ELBW babies, the highest risk, of course, in those really 23, 24 weeks. Now, the bleeding is very stereotyped to occur in this region called the germinal matrix. It's the area of what will become the caudate and the thalamus, but it's, next to the ventricle under the cortex. And as we all know, it carries a high risk of mortality and morbidity, is associated with intellectual disability and cerebral palsy through anatomical connections that we'll go through. And unfortunately, we have no disease-modifying treatments. To tell a quick anecdote, when I was a resident, I took care of a family whose baby had a terrible germinal matrix hemorrhage. And the family wasn't familiar with, had not previously had a baby in the NICU. And when we told them that their baby had this terrible brain hemorrhage, they were devastated and then followed up and said, but what are the treatments for this? And we all were very sad to have to tell them that we had no treatments. But this family were really persistent, and they would come back different days and say, well, what about a clinical trial? We'll do a clinical trial. What about a investigational compound? We'll do this. And, at every step I realized how, surprising and how out of sync we were with the adult medicine, that we had nothing to offer these babies. And at the end of that conversation, the mom looked at me and said, if you have nothing for my child, I'm going to donate her body to research. And that's really been one of the things that's fueled my passion to, discover therapies and change the course of this disease. So, back to the clinical condition of germinal matrix hemorrhage, something that's worthwhile to review for your general knowledge is the Papille classification of germinal matrix hemorrhage. This was published in 1978 now. And there's been a lot of discussion about whether this should be revised. And for instance, in our institution, our radiologists no longer call our germinal matrix hemorrhage classifications a specific grade. They say mild, moderate, to severe. But this is still something that's used frequently in the literature, and so worth reviewing. So, a grade 1 germinal matrix hemorrhage is classically defined as being confined to the germinal matrix, or it has a very small component in the lateral ventricular area. A grade 2 is now in the intraventricular space and occupies less than half of the lateral ventricular area. Grade 3 occupies more than half. And what used to be called grade 4 is now called PVHI, periventricular hemorrhagic infarction, because there's so much pressure now building up in the ventricular spaces that you basically have a hemorrhagic infarction, so a type of hemorrhagic stroke that's caused by congestion in the venous system in the brain. Now, these are relevant ultrasound images just to review all of these. And I'll thank Dr. DeVries, who posted all of these very nicely on her up-to-date article. So I grabbed these for our teaching purposes. And so here is a grade 1 in these two images. And the area of germinal matrix hemorrhage is the increased echogenicity. This is the coronal and the parasagittal view. So a grade 2, I think now you can appreciate how this is kind of spilling from the confined ependymal area right next to the ventricle into the intraventricular space. A grade 3, as we reviewed, occupies more than 50% of the ventricular area. And then the grade 4, or periventricular hemorrhagic infarction, is now spilling out into the parenchymal space. I'll say that as I was reviewing for this lecture, there are now newer systems. For instance, there's a radiologist called Dr. Al Abidi that may perform better in terms of predicting neurodevelopmental outcomes in severe hemorrhage. Also relevant, I think, for your knowledge as fellows is to review the protective and risk factors for germinal matrix hemorrhage. Now, the only true protective factor that we know of is for the mother to receive antenatal steroids, which I think we're all very familiar with. The best regimen, of course, is for her to get 2 doses of betamethasone 24 hours apart and be, as we now, frequently describe, the mom as beta complete. So there is, I think from the obstetrics management, some nuance in terms of whether that a baby gets redosed, but just to say that, as we know, is the definitive reason or the definitive protective strategy. I think the mechanism, I'll say, is not clearly elucidated, but to go over some of the hypotheses. One is that, as we know, antenatal steroids accelerate the maturation of the lungs. And as we'll go into the risk factors, hemodynamic instability is a risk factor for hemorrhage. And so if your lungs function better, then therefore the antenatal steroids are protective in an indirect mechanism. There also have been some studies, for example, that show a direct mechanism of steroids in upregulating the junctional proteins in the vascular endothelium in the brain. I'm not sure if that's actually playing a role here, and we'll review some primary data from my lab later. But I think it's still a reasonable idea that has not been, I'll say, definitively proven or disproven. Now, risks for germinal matrix hemorrhage include neonatal transport, hypothesized just to do because of like the physical aspects of transport. If any of you do neonatal transport, you appreciate like all of the bumps that happen when a very small baby has to be transported from one hospital to another. And that's because that also ties into the hemodynamic instability. So hypotension, rapid increases in blood pressure, receiving ionotropic medications, and receiving CPR are associated with an increased risk of any hemorrhage and also severe hemorrhage. Next, respiratory distress, mechanical ventilation, and pneumothorax, because they are associated with episodes of hypocapnia, hypercapnia, hypoxia, and acidemia are also associated with an increased risk. And all of these mechanisms are thought to be due to fluctuations in cerebral blood flow. And the reason why cerebral blood flow plays a role is because it's thought to disturb the amount of oxygen or potentially other, metabolites that are delivered to the vasculature. And we also have some evidence on this point, so hold that thought as well. And finally, hypothermia is also a risk factor, as well as coagulation and platelet abnormalities, I think for obvious reasons. Now, I'll just say that the role of delayed cord clamping in germinal matrix hemorrhage is unclear. There are some studies that have shown a benefit, but the only clear statistically significant benefit in this age group, the ELBWs, was for mortality and decreased transfusions. But of course, if you need decreased transfusions, maybe it's because you're more hemodynamically stable. And also, I'll say that there have been some, very good GWAS studies that haven't definitively identified any genetic factors in germinal matrix hemorrhage. And, my idea is that because it's so common in this, ELBW age range, that I think it's something that's more universal. But it's, very possible that there are polygenic risk factors for germinal matrix hemorrhage that we will learn as those technologies evolve. Now, I've alluded to this, and I think everyone's very familiar with the fact that the outcomes following germinal matrix intraventricular hemorrhage are poor. The mortality rate is high, particularly in periventricular hemorrhagic infarction. And, to review the cerebral palsy mechanism, now, because the periventricular hemorrhagic infarction is right next to the ventricles, that's where the motor and the associated white matter axons run next to the ventricle. And so these can evolve into these multiple white matter cysts. And so because of that, the affected infants are at risk of developing cerebral palsy. Now, these infants are also at risk of having neurodevelopmental impairment or cognitive impairment, and we'll go through that mechanism in a minute as well. Here, for your education, is an image of the associated periventricular cyst that can occur, the periventricular leukomalacia that we can see. Used to be much more common in the babies with severe germinal matrix hemorrhage, but we still do see it. Now, I wanted to briefly review some of the most pertinent literature about the management of these babies after the hemorrhage, but I will say that this isn't clearly my area. I'm more interested in what causes the hemorrhage. But again, it's useful, I think, to understand in this context. So, and there has been some very good research. So the Elvis trial, and here I'll give credit both to the original group, which included Linda DeVries and others, was a much needed randomized controlled trial that compared two strategies for intervening for post-hemorrhagic ventricular dilation in preterm infants. So Elvis stood for early versus late ventricular intervention study. And the idea behind this study was that they tested two time points to intervene and, do CSF diversion in one way or another in ELBW babies who had a severe germinal matrix hemorrhage. So to give you a little bit of the details, in the early group, the treatment was started after the ventricular index had crossed the 96th percentile, but before crossing the 97th percentile plus 4 millimeter line. So let me say that again to be clear. So after the ventricular index had crossed the 97th percentile, but before crossing the 97th plus 4 millimeter line. And then in the late group, it was the previous standard of care, which was when the ventricular index was greater than the 97th percentile plus 4 millimeter and the anterior width horn was over 10 millimeters. And the latter threshold was based on old observational data from Malcolm Levine that showed once you pass this threshold, progressive hydrocephalus was frequent. So essentially in the early group, they did serial LPs and then would put in an EVD and then eventually shunt them if they required it after a certain time point. So the take-home message from this is that essentially in the first group had a lot more lumbar punctures, but overall, when they looked at the scores, they had better neurodevelopment in that group. And so, a lot of groups now use this to suggest earlier and more aggressive treatment of the hydrocephalus associated with germinal matrix hemorrhage. But I'll say, at least in my practice, sometimes it's challenging to get the neurosurgeons to agree with me. So another strategy that has been discussed and trialed for management of these babies after the hemorrhage was the DRIFT trial. So DRIFT stands for drainage, irrigation, and fibrinolytic therapy. So essentially here, the neurosurgeon will go in and try to anticoagulate the ventricle to promote better CSF drainage. I think, so this has been a very interesting topic because in a randomized controlled trial, it reduced severe cognitive disability at 2 years of age. And then this was the follow-up that was published in 2020 showing that the babies who received the DRIFT therapy had overall an improved cognitive quotient at school age. I think some of the caveats to this approach are, number one, that it requires a lot of expertise because the neurosurgeon has to be very comfortable going into a very small brain and applying fibrinolytic therapy, which you can imagine makes you nervous to apply fibrinolytic therapy in the setting of a baby who's already hemorrhaging, but there actually wasn't any additional bleeding that was shown. I think the other major caveat is that all of this has been done to date, as far as I'm aware, pretty selectively in the UK. And for example, like this follow-up study was less than 100 babies. So it has not been widely replicated. So for those reasons, at UCSF, we don't do this at all. There's a neurosurgeon at Stanford, just to refer to one of our institutions that are neighboring us that I'm more familiar with. At Stanford, there's a pediatric neurosurgeon who is familiar with this technique, and so she believes in it strongly, and so she will offer it to the patients. So I think there's a lot of practice variation based on individual experience in this treatment. I'll say, on the horizon are some really exciting things. And, the Hydrocephalus Association is a phenomenal nonprofit organization that also does a lot of funding for hydrocephalus research. And I'll say that their #1 funding priority is to develop therapies for hydrocephalus that don't involve surgery. Because as you probably experienced, most babies who need to have some sort of intervention for their hydrocephalus after germinal matrix hemorrhage, or really for any reason, they're not definitive therapies. They often have to go in and have multiple shunt revisions. There's a woman who works at the Hydrocephalus Association who herself has had over 40 surgeries. So I think there are new molecular therapies that are on the horizon, and this is one example. This is Dr. Cameron Sade. He was in Maria Letnin's lab at the time that he did this research, and they developed this mouse model where they injected age-matched whole blood into the interventricular space. And they found that there were differences in this NKCC1 channel that is associated with the potassium ion flux. And that after the hemorrhage, that they had increases in the channel expression and also in the potassium flux, but it seemed like it wasn't sufficient to overcome the hydrocephalus. And so in this model, they then gave the mice more of this channel using a viral vector, an AAV. And what they found is that they were able to improve the hydrocephalus just by adding more of these channels to the choroid plexus. So I think it's really exciting that folks are now starting to use these, molecular therapies to potentially be able to do less surgeries in our babies for this condition in the future. Okay, so that was a review of the epidemiology and the clinical manifestations of germinal matrix hemorrhage. Now we're going to discuss some newer work from my lab on human brain vascular development. One of the things about studying the vasculature is they're really beautiful, so I hope you'll indulge me as I show some of my favorite pictures. So this is a picture from the developing mouse brain. This is actually the germinal matrix, the area that's prone to hemorrhage. And the blood vessels here are in gray, and the dividing neural stem cells, their nuclei are in purple. And something that we came to appreciate was that the blood vessels make these beautiful filopodia that seem to be preferentially contacting the neural stem cells. And so we did a lot of studies in both human and mouse. But what we found is that the blood vessels, they extend out these filopodia, they contact the neural stem cells, and then they tell them to divide and make neurons. And if you have too many filopodia, then you tell the stem cells to become neurons too quickly, and then overall, they're able to give rise to less neurons. And so this is just one example, and I'll give many, of the fact that, it's a really delicate period of time when we're taking care of these babies who are in the ELBW timeframe, because their blood vessels are developing and their neurons are also developing. And these two processes, not only are they simultaneous, but they're interdependent on one another. And so one of my passions in the lab is to figure out what are these different signals so we can target one or the other to work on germinal matrix hemorrhage. So to review some of the anatomy, these are gross pathological specimens from babies who passed away from causes not related to germinal matrix hemorrhage with no hemorrhage, to highlight this area. So, I'm going to talk about the germinal matrix in this talk because that's the clinical pathological term. But in fact, in neurodevelopment, the term ganglionic eminence is used, and it's the same region, but it's just, different fields have different names. And in these specimens from 14, 21, and 33 gestational weeks, I've highlighted the ganglionic eminence or the germinal matrix just to show you what proportion of the brain it occupies at these different developmental ages. And I think something that becomes very apparent when you see these pictures is just that the germinal matrix is occupying much more of a proportion of the brain at earlier gestational ages. And by the time a baby's born at 33 gestational weeks, there's only a remnant of this structure left. And so whatever's going on in the blood vessels in this area, by the time the baby's outside of that window of vulnerability, the blood vessels and the structure itself are gone. Now, what happens in these structures? So we're learning a little bit about the human, but much more is known about these areas in the mouse. So I'll go back, if you'll forgive me, to cover a little bit of the mouse data, because it was very well done too. So these are now schemas of coronal sections of the developing mouse brain. And again, the ganglionic eminences are here. And in fact, anatomically, you can break them up into lateral, medial, and caudal ganglionic eminence according to their location. And in general, based on lots of mouse data, we know that these structures produce the majority of GABA-containing interneurons, so the inhibitory neurons of the brain. And they're born in this region, and then they migrate up and integrate into the cortical circuitry. So I think these are useful parameters to remember about the phenotypes of a baby who has severe germinal matrix hemorrhage. So they have the cerebral palsy, the motor phenotypes, because those motor neuron axons run next to the ventricle. And then they often have cognitive impairment because the area that's making their inhibitory neurons is also severely damaged after the hemorrhage or in the course of the hemorrhage. So why are the blood vessels in this region so prone to hemorrhage? What do we know about the blood vessels in this area in general? So again, starting from mouse, we know that the blood vessels, at least the traditional thinking is that they start outside of the brain, and potentially in response to hypoxic signals, they dive into the growing neural tissue, then they elaborate up by about mid-gestation to the most dorsal aspect of the brain, and then the most medial aspect, and then they grow out with the growing neural tissue. But when I started this work, when I was a fellow, in fact, there was nothing that was known about human brain vascular development, and so that's where I decided to focus my research efforts. Now, to take a step back, let's review the different types of endothelial and mural cells in the brain, but also throughout the body. So I think most of you are likely familiar with arteries and capillaries and veins or venules. Those are the traditional 3 types of endothelial cells. And something that I talk about to, my teams and my fellows when I'm on service is, if you think about pulmonary hypertension these days, we have mechanisms that target different types of blood vessels for pulmonary hypertension, right? Like it's the pulmonary arterial hypertension, the arteries that are mostly the target of those, versus, we've likely all taken care of babies with pulmonary vein stenosis, where there's a stenosis where those veins come back to the heart. And that's a different type of endothelial cell. And we actually don't yet have targets specifically for that, or not very well proven ones. That can target and make those types of endothelials dilate. So something I'm really interested in is the heterogeneity of these different types of endothelial cells. So as we know, they compose the lumen of blood vessels, and in the brain, they're connected by tight junctions, which are important for the blood-brain barrier. I'll also say during development, there are 2 other subtypes of endothelial cells, tip cells, which are the ones I showed you with that philopodia, as well as mitotic, which are just dividing endothelial cells. Now, mural cells is an umbrella term that I use to describe the cells that sit on top of the endothelial cells. They're also called pericytes, smooth muscle cells, and fibroblasts, but the distinctions between these are a very active, hot topic within the field, I'll say. In general, they're a heterogeneous, relatively undefined support cell population. We do know that they're required for the formation of the blood-brain barrier based on mouse studies that came out in 2010. And on the opposite end of the life spectrum, they've been implicated in neurodegeneration. So one of the things that I think about is that the mural cells are likely kind of the signaling hub for the vasculature. So they control the endothelium below them, and they're also kind of talking to the neural cells that sit on top of them. So again, to show one of my favorite vascular pictures. So one of the things that we realized is that those endothelial philopodia that exist in the developing mouse brain, we can also find them in the developing human brain. And so this is now showing the endothelial cells in green and the mural cells in blue using immunohistochemistry for the specific markers. This is at a gestational week 17 in the human ganglionic eminences. And one of the things that we found out when we were looking at this was that there are a lot of philopodia that are located right next to the ventricle. So this was quantified here, where we called the area right next to the ventricle zone 1. And this is most prominent in this earliest gestational week, but it's still going on when we can take care of these babies in the NICU between 21 and 25 gestational weeks. So this led us to the idea that these blood vessels might be actively dividing or angiogenic. And that's important because I think if we need to know if we're targeting a vascular bed that's actively growing. And so another criteria for that would be that these blood vessels have more branches. So we also quantified and found that they have more branches. And then angiogenic vasculature should also be dividing. So we looked at this with a marker for dividing cells called Ki67, and here's our immunohistochemistry for endothelial and mural cell markers and dividing ones. And we could capture this as a dividing endothelial cell. And we quantified that there were also more of them dividing right next to the ventricle. And there are also more mural cells that are dividing right next to the ventricle. So I think in general, this is starting to help us build a picture of what the blood vessel development looks like. And here's a mosaic, actually, that's on my wall as well, that we had an artist who helped us conceptualize what the different blood vessel cell types look like in this region. And then we can start to think about why might these specific types be vulnerable to rupture. So I think this was nice morphological and histological data, but then we wanted to use some more cutting edge techniques to understand these cells better on a molecular level. So to do that, we used techniques called FACS, or fluorescence activated cell sorting, and single cell RNA sequencing that I'll get into. So again, this is a schema of the cell types that we're interested in. So the endothelial cells, the mural cells, these are the markers that we used for FACS to pull them out, as well as microglia, which are an immune cell type in the brain that we'll get back to at the end of the talk as well. And so for the aficionados, here are our FACS plots. And essentially, FACS works by taking a cell surface protein that's present on the surface of the cell. You apply an antibody that's conjugated to a fluorescent dye, and you can use that to separate your different cells of interest. And then you can put them into a tube, and so that you can collect them. So with those cells, then we use single cell RNA sequencing, which is an increasingly popular technique. Essentially, you can take a single cell and pull out all of the RNA molecules. And the RNA molecules are a proxy for what the proteins that the cell is making. So in that way, you can kind of get a picture of what functionally the cells are doing. You show single cell RNA sequencing data in UMAP plots. So that's what these are. And each one of these dots represents an individual cell, and there's a lot of bioinformatics that goes into the back of it, but you can definitely learn it if you're interested. Everybody who is in my lab codes, and nobody codes when they started, so I think it's definitely learnable and achievable and pretty cool. So what this shows, though, the UMAP plots are they're putting these different dots, which are the different cells, next to one another if they're similar to one another. So it was reassuring to see that we know that endothelial and mural cells are different than one another. And when we put them in a UMAP, they show that we have a group of mural and a group of endothelial cells. We were interested to see whether we could identify distinctions in these cells based on their area, whether they were from the cortex or the germinal matrix, ganglionic eminence, and whether there were dramatic differences by age. We didn't see them in this analysis, but we can go into why I think that is, if anyone's interested at the end. So then we wanted to zoom in a little bit on the endothelial cells first. And using this technique, we were able to identify all the different subtypes that we could find also morphologically. So we found arteries, capillaries, veins, and the tip and mitotic cells. And then the way that you identify these cells is to look for specific gene expression, and then you can map that gene expression using the UMAP as well. And here we're showing the high expression, for example, in arterial genes like fibrillin 5 and GJA4, which is a gap junction and elastin, and that those are present at high levels in the cells which should be expressing them highly, which are arteries. And then these are examples for all the different subtypes. And then we wanted to go back and find these in the tissue. And then we used a technique called RNA-scope, which is a newer in situ type of technique, where these little dots are showing individual RNA molecules. So in this case, ADGRG6, which is a G protein coupled receptor, which is supposed to be expressed in veins. And you can see that these puncta are present in this bigger blood vessel a little bit further back from the ventricle. So here in this schema of a 15 to 17 week coronal section. But here I showed you at the beginning of the talk that there were these cells with these filopodia that are supposed to be tip cells, and we could find their RNA molecules right next to the ventricle. So that's good. That all makes sense. All of the different techniques are showing the same thing. And then we could identify these bigger blood vessels, which are a little bit further back from the ventricle, which express GJA4 and fibrillin 5. So these are different RNA molecules that are specifically expressed in arteries. So this is just saying how we're starting to map out specifically where the different subtypes are located and what are their molecular signatures. Now, to go into the mural cells for a minute, I think this is a cell type that folks are less familiar with. So I'll start with the mural cells on the arterioles and the precapillary arterioles. So these are smooth muscle cells that I think we are all more familiar with. Now, once you get to the capillaries, this is a type of mural cell that's called a pericyte. People get really excited about pericytes because they're the ones that are supposed to be, for reasons that we don't know, making the endothelial cells have the blood-brain barrier. But I'll say that so little is known about these cells, but by the time you go from the capillaries to the postcapillary venules and the venules, we don't even have names for these mural cells. There are also fibroblasts that we can find next to the ventricles, and these were discovered in a paper from Christopher Betschultz that was published in Nature in 2018. And in general, the fibroblasts seem to be distributed on the bigger arteries and the bigger veins and largely absent from the capillaries. So then we wanted to go back into our data and see if we could find these different subtypes already present in the second trimester human brain. And the short answer is that we could. So we found smooth muscle cells, classic pericytes, and fibroblasts, and also some mitotic cells, mitotic mural cells. And we did the same thing where we used RNA-scope to go in and actually find these RNA molecules on cells which look like mural cells, and we could find them. So here's an RNA molecule for ATP1A2 and KCNJ8. So these are different channels, and we could see them clustered in these periventricular cells that I'll show a movie of in the next slide. We also could find these fibroblast markers. And smooth muscle cells are harder to find. I think they're rare, especially at this very young gestational age, but we could identify a few of them. And then again, if you'll indulge me here, some pretty pictures of blood vessels and the RNA molecules that they're making in the developing human brain. So I think something that was, interesting about this, to zoom out for a minute, is just to realize that all of the different subtypes of endothelial and mural cells that are present in the adult human brain, they're already existing in the second trimester. So it just says that for whatever reason, we need this full repertoire of different subtypes of blood vessel cells really early, but there might be distinctions that are leading to the hemorrhage vulnerability. And I think on that note, some of the a few good studies that have looked at the cellular mechanisms of germinal matrix hemorrhage, interestingly, have implicated the pericyte subtype of mural cells specifically. So this is work from Praveen Balaba's group, who's done probably the best germinal matrix hemorrhage research, really, as I entered the field. And so what he showed in this paper from Journal of Neuroscience in 2007 is that if you look in the brains of humans at ages that are relevant to hemorrhage, 17 to 25 gestational weeks, NG2 is this mural cell marker for pericytes. And it's fairly obvious that if you look at the blood vessels in the germinal matrix compared to the white matter where we don't have hemorrhage, that there's less of the green pericyte coverage. And in addition, we think that the pericytes might be making extracellular matrix, which potentially just helps, to make the blood vessels, more secure or strong. And they did, again, immunohistochemistry, so where they just looked for the protein of fibronectin, and they saw in this other paper that there's less fibronectin in the germinal matrix compared to other areas. So I think this is, really good data, and it points at potentially a cell type that might be, key in this pathogenesis. But what we don't know is why there might be a paucity of pericytes. And so that's something that really excited me. Where are these cells coming from, and who are their progenitors? So, that I think nicely leads in to what we're now calling the two-hit hypothesis for germinal matrix hemorrhage. So we'll start with the overarching idea and then work through the pieces. So what we think now is that there's a vascular cellular immaturity in the germinal matrix specifically, but then you need to have a secondary hit on top of that. And I think hypoxia or oxidative stress, hypoxia or hyperoxia, so some dysregulation in the oxygen tension in this region, and or inflammation are two good potential targets for two reasons. One is that the clinical data that I reviewed at the beginning of the talk. So, we know that babies who have fluctuations in their hemodynamics are vulnerable to hemorrhage. And also there's association with babies who have sepsis, right? So I think now we can start to try to figure out what's the molecular mechanism behind this. So to start first with the first part of this hypothesis, the vascular cellular immaturity. So here, again, I'm showing a schema of some of the different subtypes that we think might be present preferentially, and especially showing some of these subtypes that are associated with earlier developmental stages. So like the tip cells and the mitotic cells. But then I mentioned that, Praveen Balaba's data showed that there's a paucity of pericytes. So if there's a paucity of pericytes, what comes before the pericytes? So that's something that we're really interested in. And we have this idea that maybe the smooth muscle cells are the stem cell that gives rise to a pericyte. So to show you how we got to that idea, here I'm reviewing our FACS plots and our single-cell RNA sequencing. And then using the single-cell RNA sequencing, we applied an algorithm called RNA velocity. RNA velocity is a bioinformatic trick that takes the spliced to unspliced ratio of mRNAs with the idea that mature RNAs are going to be more spliced. So if you have more unspliced mRNAs, you're potentially a more immature cell. So using that, you can hypothesize or extrapolate who might be the stem cell. And so using that RNA velocity bioinformatic algorithm, it showed that smooth muscle cells potentially are the progenitor that gives rise to pericytes. And this was really exciting to me when we found this, because I thought that makes sense. Now we know why there might not be enough pericytes, because they haven't come online yet. So that's our hypothesis. As you can see, this was published in 2022. So now we are working very hard to try to see if this is why that there are less pericytes. And I'll show you some, data on how we're doing this. So one, we're going back to RNAscope. And this is a pretty picture I like, but also for the information that it provides. This is a human 21 gestational week brain. This is showing the germinal matrix. And we're doing an RNAscope or looking for the RNA molecules for RGS5, which is a pan-mural cell marker, as well as PDGFR beta. And RGS5 really beautifully delineates all of the vascular cytoplasm. And so we can use this to kind of track the blood vessels over time. So we're overlaying this now with different markers specifically for smooth muscle cells and for pericytes to kind of test just the temporal appearance of these different cell types. If we look really early, are there no pericytes? If we look later, are there more pericytes and fewer smooth muscle cells? And then eventually what we want to do is correlate also RNA molecules for blood-brain barrier effector properties that we think might provide more strength, quote unquote, whatever that means molecularly in this region. So here I'm just showing you one example picture where here's the RGS5 and PDGFR beta. So these are pan-mural cell markers. Smooth muscle cell markers include SDC2 and ACTA2. And we can see that they're more present in the bigger blood vessels, and they're absent in these smaller blood vessels. So at least now we know we've got good markers for what we think are smooth muscle cells, and we can use this to track the appearance of these cells in different regions and over time. So now let's get into the second part of the hypothesis. So it's not just you have vascular cellular immaturity, but maybe that's the ground state for being vulnerable to a second hit, which we think might be hypoxia or inflammation. So to look at this, we've actually gotten the blood vessel cells from 2 babies after they passed away with germinal matrix hemorrhage, and within the first week. So these were more acute cases, let's say. In these cases, so we did their same FACS strategy. This is just showing a different version of these plots. And I'll note, in our strategy as well that we collect microglia, because we'll get back to their role potentially in inflammation. So here's another UMAP where what we were first happy to see is that the blood vessel cells from the cases, they can cluster with the controls, because one concern in doing this experiment is that the blood vessel cells are just going to be destroyed and we're not going to be able to get any good information from them. But in fact, they do have some good RNA. And so then we can dive into this more deeply and look for exactly what might be going on. And one of the first things that we did was look for the relative proportion of the different subtypes of vascular cells. And something that's really striking is that we saw that there are fewer of the dividing ones, so the mitotic mural and mitotic endos. Again, this is n=2. We're waiting for another case where we can potentially corroborate this, or we can use different techniques to go back to some of our banked tissues as well. But I think some of this is starting to make sense because we know that those mitotic ones are right next to the ventricle. The other thing, as we looked specifically for the RNA molecules that are present in those cells, is we found when we used a volcano plot to compare the genes that are higher in the control versus the GMH cases, that we saw a lot of terms and genes related to oxygen levels. So our most significant term was response to oxygen levels, and there's a lot of other stuff about HIF, as well as oxidative stress. And so then looking more carefully, these are different feature plots where we're looking at, the UMAPs of our cases compared to our controls for hypoxia-related genes. So here's apolipoprotein D, which you might have remembered is another apolipoprotein like apolipoprotein E, which interestingly is associated with Alzheimer's disease, which we're understanding has an increasing vascular component. And then we also, picked out these other just HIF genes. So HIF1A, which are the hypoxia responsive genes. EPAS1 it's an endothelial specific HIF. So it's also called HIF2 as well as HIF3. So we're trying now to follow this up by looking at the tissue and seeing whether, especially HIF2 might be highly expressed after hemorrhage, because patients, there are now HIF2 inhibitors that have been FDA approved, because HIF2 is involved in the pathogenesis of renal cell clear cell carcinoma in patients who have von Hippel-Lindau. So there's already a therapeutic potentially that we could apply in a clinical trial or in a mouse model to start off with, if we see that that could be involved in the pathogenesis of germinal matrix hemorrhage. Now, to get back to the tight junctions and the junctional proteins, these are violin plots where we're looking at specific genes in our different subtypes. And, when we look at our cases versus our controls, we don't see obvious differences in the junctional proteins. So this is showing the adherence junctions, and this is showing the tight junctions. Again, this is the RNA level, not the protein level. So this might not be the whole story, but I think it's leading me away from thinking about junctional proteins as being less functional or underdeveloped in these cells. Again, so now, getting back to our hypothesis, that's why I think potentially hypoxia or, oxidative stress might be playing a role, and how potentially we could think about targeting it therapeutically. Then to get a little bit more into inflammation, now this is, again, the FACS plots that I showed you before, but this is just highlighting the fact that we can collect myeloid cells or microglia. And microglia are a hot topic these days. I don't know if any of you are working on maternal immune activation, MIA, but it's thought that, that some sort of immune activation during pregnancy could be leading to a variety of different neurodevelopmental conditions in babies, and autism has been one that's been, associated in some literature from, investigators that I know at UCSF. But I think it's a reasonable hypothesis also that this could be contributed to germinal matrix hemorrhage. And here I'm going to highlight some work from a graduate student from my postdoctoral lab. Her name is Jai-Pei Chen, and we worked very closely together. I think this is just really exciting results as well. So she, again, took in the cases where we had the germinal matrix hemorrhage, we did those FACS plots and pulled out the microglia specifically. And then she did an experiment bioinformatically where she compared the control microglia to the microglia that were present in germinal matrix hemorrhage. And something that was really interesting was that she found in this immune cell population that there were a lot of neutrophil-related genes that were expressed that she didn't see in control cases. So I think this pointed her to the fact that there might be neutrophils that are making it into the brain after germinal matrix hemorrhage or in the course of germinal matrix hemorrhage that could be involved. And so to test this, she took a pregnant mouse and she injected some of these neutrophil-related factors, they're called ELANE and CXCL16, directly into the mom, so kind of simulating the maternal immune activation. And amazingly, she found that these mouse pups, developed hemorrhage. So here's showing some of her data where, the red here is just showing red blood cells, and that she got red blood cells into the, ventricular zone in the germinal matrix after this hemorrhage when she did it at a specific time frame. And then she also took these factors and she provided flow in a microfluidic model of blood vessels. And here is how the blood vessels look in a control condition. But when she added these neutrophil-related factors, that they're just, for lack of a better term, like destroying the vascular cells, or at least their connection. So, this is leading us also to think potentially about the role of microglia in germinal matrix hemorrhage. And here are some schemas to summarize this data. In data that I didn't show you in the earlier part of her paper that's currently in review, she showed that the microglia already interact with the vasculature in some really amazing and beautiful ways, and maybe they promote their normal development. But inflammation then can disrupt the vasculature, potentially in germinal matrix hemorrhage. So, that's the summary of all of the data from today. And I think it's just to, to wrap this all up and put it together, I think something that we're trying to do is harnessing vascular stem cells to hack neurodevelopment and disease. I showed you how we can reconstruct developmental cell lineage with next-gen vascular reagents. We can study neurovascular interactions and data that I didn't get to show you, but we're looking at too. And then finally, we're using this information to try to target therapeutics for neurovascular disease. There are also other genetic, conditions like collagen 4 mutations that we're interested in well, but, germinal matrix hemorrhage is something I'm passionate about. And finally, I'll say thanks to our lab, our funding sources, and our collaborators. I put my contact info on this slide, and please feel free to reach out. I think about germinal matrix hemorrhage, about being a physician scientist or a woman or a mom in this field. I think any way I can be helpful.